Chapter 20 of the 2018 Clinical Practice Guidelines is on diabetes and transplantation. This chapter was written by Peter Sr., Mohammed Al-Mithal, Andrea Miller, and Bray Patey. Key changes in this chapter include new information on post-transplant diabetes with screening recommendations and management recommendations. Pancreatic transplant, or islet transplantation, leads to restoration of endogenous insulin secretion. This in turn results in an improvement in A1C as well as reduction or elimination of hypoglycemia. Through this mechanism, there is also a reduction of diabetes-related complications. In the case of islet transplantation, it may stabilize microvascular disease, and in the case of pancreatic transplantation, there is evidence to show improved microvascular outcomes, lipids, blood pressure, and carotid intimal media thickness. This table compares and contrasts islet versus pancreas transplantation. Both result in improved A1C and protection from hypoglycemia. Islet transplantation is more short-term with respect to insulin independence, whereas pancreas is longer-term. However, islet transplantation is minimally invasive with local anesthesia, but pancreas transplantation is major abdominal surgery. The procedural risks are much lower with islet transplantation, and these include hemorrhage from hepatic puncture, branch portal vein thrombosis, whereas the procedural risks are much higher with a pancreas transplantation, including thrombosis of graft, anastomotic leak, pancreatitis, infection, and hemorrhage. And in terms of immunosuppression, both types of transplantation require it, and they require it for the duration of transplant. For individuals with coexisting renal disease, simultaneous kidney-pancreas transplant in patients with type 1 diabetes and end-stage renal disease can improve renal graft survival. So therefore, if an individual is being considered for renal transplant, then they should also be considered for simultaneous pancreas transplant. So the decision-making model is listed here. Let's start off on the far left. So in someone who is living with type 1 diabetes with end-stage renal disease, then their renal transplant options include living donor kidney, cadaveric kidney, or simultaneous kidney pancreas. If this person has a functioning renal transplant, then they have the option of either islet after kidney or pancreas after kidney. However, if an individual does not have any end-stage renal disease, then they're isolated to either islet transplantation or pancreas transplantation. What is the pancreas graft survival based on the different types of transplantation? So simultaneous pancreas kidney seems to have the best survival over time, with 83% at 1 year, 69% at 5 years, and 51% at 10 years, and 33% at 15 years. And as you can see, pancreas after kidney or pancreas alone have slightly lower levels. In the case of islet transplantation, insulin independence rates also drop over time, with 70% independence at 1 year, 10% independence at 5 years, and the 10 and 15-year data are not yet available. Now switching gears to a different concept, which is that of someone undergoing total pancreatectomy for benign pancreas disease. In an individual like that, there is now an option of islet autotransplantation if they happen to get their pancreatectomy at a center that has such facilities. The reason for this is because a total pancreatectomy leads to absolute insulin deficiency and loss of glucagon-secreting alpha cells. In addition, they also lose the exocrine function of the pancreas, affecting absorption of nutrients and changes to the gastrointestinal anatomy. Post-pancreatectomy diabetes is associated with an increased risk of hypoglycemia given the lack of glucagon. So islet autotransplant is an option to maintain endogenous insulin production and prevent or ameliorate brittle diabetes. No immunosuppression is required given that it is the patient's own islet cells that are being transplanted. However, islet autotransplantation is not recommended when pancreatectomy is for malignancy. A new topic that was added to this chapter was post-transplant diabetes, which can be seen in the case of solid organ transplantation. So pre-transplant, we suggest that screening tests be done for individuals looking at fasting plasma glucose and A1C, as well as an assessment for cardiovascular risk factors. These should be managed appropriately prior to the transplantation. Post-transplantation, in the immediate post-op period, post-lunch capillary blood glucose monitoring makes sense because many of these patients are on steroid therapy in the morning, resulting in hyperglycemia midday. If in fact there are abnormalities of the capillary blood glucose monitoring, then the diagnosis should be confirmed with a fasting blood glucose or an oral glucose tolerance test. A1C, however, is not reliable immediately post-transplant. At the 3-month mark, it is recommended that solid organ transplant individuals have an A1C, and same at the 12-month mark and then annually thereafter. The management of post-transplant diabetes includes healthy behavior interventions, individualized glycemic targets, and of course pharmacotherapy. Pharmacotherapy preference would be for drugs which do not cause weight gain. Sulfonylurea should be avoided, particularly if the individual has had a pancreas transplant or is renally impaired. And insulin is often recommended if osmotic symptoms or severe hypoglycemia exists. Recommendation 1. Individuals with type 1 diabetes and end-stage renal disease who are being considered for kidney transplantation should also be considered for simultaneous pancreas kidney transplantation. Recommendation 2. Individuals with type 1 diabetes with inadequate glycemic control, characterized by marked glycemic lability and or severe hypoglycemia, despite best efforts to optimize glycemic control, and who have preserved renal function or had a successful kidney transplant, may be considered for islet allotransplantation or pancreas transplantation. Individuals undergoing total pancreatectomy for benign pancreatic disease may be considered for islet autotransplantation to prevent the development of diabetes where suitable facilities are accessible. Recommendation 4. Individuals undergoing solid organ transplant should be screened for diabetes and cardiovascular risk factors prior to transplant and should be screened for PTDM after transplant, using A1C at 3 months, 12 months, and then annually, or with an OGTT if A1C is not reliable. The other option is a 2-RO GTT or post-lunch CBG in the first 3 months after transplant. Recommendation 5. Individuals with post-transplant diabetes should be treated to individualized glycemic targets, receive health behavior interventions similar to those recommended for people with type 2 diabetes, receive antihyperglycemic agents which do not provoke weight gain whenever possible unless contraindicated, avoid insulin secretagogues if they have renal impairment or poorly functioning pancreas transplant, and finally receive insulin for metabolic decompensation or symptomatic or severe hyperglycemia. Key messages from this chapter. For people with diabetes and end-stage renal disease, kidney transplantation improves long-term outcomes compared with dialysis. For people with type 1 diabetes and end-stage renal disease, simultaneous pancreas kidney transplantation can improve kidney graft survival and result in prolonged insulin independence. For people with type 1 diabetes, pancreas or islet allotransplantation improves glycemic control, prevents severe hypoglycemia, even in the absence of complete insulin independence, but with the risks of long-term immunosuppression. In people undergoing total pancreatectomy for benign pancreatic disease, islet autotransplantation can prevent or ameliorate brittle diabetes. Post-transplant diabetes is common after solid organ transplantation and is associated with increased risk for mortality, cardiovascular disease, and graft loss. Key messages for people living with diabetes. Diabetes sometimes damages kidneys so badly that they no longer work. When kidneys fail, one option is a kidney transplant. For certain people with type 1 diabetes, pancreas or islet transplants may help stabilize blood glucose levels. Your healthcare diabetes team can discuss the benefits and risks of these procedures with you. For more information, please visit guidelines.diabetes.ca to access the chapters, slides, videos, and interactive tools. And also, please remember to download the app from Google Play or the App Store. Thank you very much for your attention.